Assalamu alaikum, hello and welcome to another episode in our second series of The Health Show, here only on the Islam channel, with me, Alistair Greener. Now, every week we're joined by a health expert, and together we discuss different ways of preventing and treating health issues or concerns that we or our loved ones may face. Now, many of these issues are caused by an unhealthy lifestyle or a lack of knowledge when it comes to seeking professional advice. So that's why we're here, so you can be better informed regarding the various health issues that we discuss with our experts on the show. And hopefully you'll be able to change your health and lifestyle for the better. If you'd like any further information on any of the shows or the topics that we discuss on the shows, then please do get in touch. healthshow@islamchannel.tv. Now, we should say and stress that should you suffer from any medical problems or have any concerns, it's always highly recommended that you contact your doctor or GP, as the Health Show gives you an alternative viewpoint to the health topic being discussed. On with today's show, where we're looking at pregnancy care. So again, if you're on this beautiful journey or if you know someone who is, then please do stay tuned, as we'll be highlighting some of the key factors that women should be aware of when pregnant. Now, to help us, I'd like to welcome Dr Dyah Prawesti, who is an obstetrician, in other words, a doctor specialising in pregnancy care. Dr Prawesti completed her medical training in Jakarta in Indonesia, and continuing her training, she's been working in the UK since 2013 and was awarded membership of the Royal College of Obstetricians and Gynecologists in 2016, and she currently works as a specialist registrar in obstetrics and gynecology for the NHS. Good morning. Lovely to see you. Thanks for joining us.
Thank you very much. It's my pleasure. Thank you.
Now, just before we talk a little bit more to Dr Prawesti, let's have a look at a 36-year-old Swedish lady who's become the world's first woman to give birth after receiving a womb transplant. And this has been reported by the medical journal The Lancet.
After more than 15 years of extensive research at the University of Gothenburg, with more than 40 scientific articles and 7 successful uterus transplants, the world's first baby to be born to a mother with a transplanted uterus, the baby was 40 centimetres long and weighed 1,775 grams at birth, all of which is perfectly normal for a baby born at the end of week 32.
They are very good, I would say. They are happy, of course. They are in good health, both of them, and also the partner. They are now trying to form a new family, and that's what's occupying their minds right now. But their health is imperfect.
So she's still on her immunosuppressive drugs because she has a uterus, and she has the option, if it's safe for her and for another pregnancy, to keep it to try for another pregnancy. And the baby has been fine all the time and is breastfeeding and growing as it should do. I think this is not going to be routine clinical care or routine surgery until many, many years from now.
Dr Prawesti, again, thank you for being with us today. It's amazing, isn't it, watching that video, how much technological advances have helped women in their pregnancy.
Absolutely, and I suppose from now on we would expect like more intervention, more research will be put in order to help all these unfortunate women who, for whatever reason, either they don't have the womb since they were born, or they might need to lose their womb throughout their lives. So I would expect that we would see more in the future soon.
Now, before we get into the specifics of obstetrics and the work that you do, many people will be watching, considering their faith and thinking about the different elements of what they believe in, what technology is able to help them with, and wondering where the boundaries are. How do you help women in that respect? Because I know you have many Muslim women who you look after.
Yeah, absolutely. So probably I would like to start that in Islamic tradition, Islamic teaching does not stop humankind to sort of progress with their research, with their seek of knowledge and all those type of things. Now, when we come to a certain area, which will then be considered as whether it is prohibited or whether this is allowed by the Sharia law, then we should then come up with a discussion between the expert, which is the professional, the researcher, the doctors, the medical team, and with the what we call as the ulama, or the person who is like scholarly known and sort of trained in Islamic tradition. And they should sit together and discuss which sort of medical intervention that is allowed and which one is not allowed. And we as a professional, as well as the patient who seeks further treatment, should then seek their opinion with regards to that. And I suppose in this age where communication between a lot of different experts in different areas is possible, I think it is very possible for us to then come up with a solution with regards to either certain medical intervention needed by someone and what's the Sharia law, what is the fiqh law opinion with regards to that.
So basically have the conversation.
Exactly, absolutely.
Let's step back a minute, because it was important, I think, to discuss that, given the level of intervention that we saw there, and to try and put that into perspective. But let's look at your role as an obstetrician. Now, people often hear the term gynecologist, they hear obstetrician, they hear, pre, post-natal nursing, and so on and so forth. Give me an idea of exactly what an obstetrician does.
So basically, traditionally, it will be someone who look after someone who is pregnant from the period of antenatal care, that's throughout the pregnancy itself, and then throughout the intrapartum care, where a woman delivering their babies, and then postnatal period, the period after a woman delivered their babies. So that's sort of the traditional understanding about what obstetrician is. Now, we know that, especially in the UK and many other places in the world, those sort of care or responsibilities are shared between few professionals. A midwife normally look after women for their sort of care throughout the pregnancy, delivery and postnatal care, where they are deemed to be low risks. Now, if they do have some medical problems before the pregnancy, or the woman develop sort of complications in pregnancy, then it's going to be obstetrician responsibility to look after them.
So you only really get called in when something isn't quite right.
Exactly.
And what is it? I mean, obviously there's a multitude of different things that can happen. Give me an idea of the most common things that could affect a woman's pregnancy. So
I would say a lot of women, they normally, women in their reproductive age, where it is possible for them to get pregnant, they're normally young, they're normally fit, they're normally healthy. Now, when they come into this pregnancy, then they should be still at the same stage of sort of fitness. It would be like completely different if you look at other people who being looked after by doctors. They probably do have some medical problems, but pregnancy itself, it's not a medical problems. It's just a different condition. So most of women, they will be young, fit and healthy. However, pregnancy then imposed them to a completely different physiological changes. Some women, because of different reasons, either it's there before the pregnancy, some condition, or a condition that developed in pregnancy, they do get some problems. There are problems that are specific in pregnancy, say what we call as a diabetes in pregnancy or gestational diabetes. So women who is like completely fit and healthy before, whilst they're pregnant, because of these physiological changes, they can suffer from diabetes. So it could be
something that you had no way of predicting. It's just when pregnancy happens, your body changes and therefore the circumstances change.
Yes, exactly. That's how it is. And one of the other things that is, again, quite common is what we call as a preeclampsia, which is a condition where a pregnant woman can develop high blood pressure, leaking of protein from their kidney. And normally, most of the time, all of this condition will then resolve after the pregnancy.
Now, one of the things that we hear a lot about, and women obviously want to do everything they can to make sure that their new child is going to be fit and healthy, the pregnancy will go well. But there's a lot of old wives' tales out there at the same time, aren't there, about you should eat this, you shouldn't eat that. Give us some real basics of what is absolutely a no-no during pregnancy and some of the things that you absolutely should be doing during pregnancy for good health.
Sure, yeah. There are, unfortunately, in this era of information, you could actually Google stuff, and unfortunately, not all of them are valid. So I would suggest that if a woman planning for a pregnancy or a pregnant woman would like to, try to get some more information, they should consult their midwives, or there are websites that the NHS actually develop to give a lot of advice with regards to how to lead your life in pregnancy. But most of the time, as I mentioned before, pregnancy is not an illness, it's not a medical condition. So basically, a healthy, fit young woman should be able to carry on with their daily activities. So lead the new lifestyle probably is only limited to them who is then severely affected by their pregnancy. Unfortunately, there are some women who are severely affected by their pregnancy, but it's just a minority.
And what percentage of women do you think, on average, as a very loose figure, would be in a situation where they would need the help of an obstetrician?
I think these days, because of lots of changes, because obviously women are more aware, and obviously we as a medical professional, we sort of like more aware, and we try, like, our aim is to sort of limit the morbidity and the mortality of pregnant women, because that's one of the key indicators of how good a nation look after the health of their citizens. That's why I think more and more probably now these days that women actually being cared or shared care between the midwife and their obstetrician. But mostly, most women, I probably would say 60 to 70% women, they do still are deemed to be low risk, that the midwife should be capable of looking after them. So again, they were just
working with their midwife, and I presume then when the midwife is made aware of changes that aren't normal, that's the point the obstetrician steps in.
Yeah.
What sort of changes could a pregnant woman notice that would make her realise something's not quite right?
So I think it's supposed to be different from a different condition. Now, in the UK itself, and the WHO also now try to disseminate lots of screening that we offer in pregnancy in order to then screen women who are at risks at the beginning, so that if those problems do develop later on, we are aware and we anticipate that before that develops. There are some screening programs, and those screenings are then sort of divided for mums and babies, because both of them, mum's part and baby's part, they can develop problems.
And are these
pregnancy.
automatic screenings, or are they screenings that only certain vulnerable members of society would be eligible for?
Yeah, so there are screenings that we offer to women as a routine. So every pregnant woman would get that screening if they consented to this, because not all of them would be happy to have this test. And there are screenings that we target specific vulnerable women. For example, screening for diabetes in pregnancy, for example. We know that people with a certain background, as in ethnicity, their weight before the pregnancy, or their family history, diabetes in their first-degree relatives, are a very, very dominant risk contributing factors for the risks in developing diabetes in pregnancy. Those women, then we would normally offer the test to pick up these should they develop in the pregnancy. But other women who are deemed to be low risks in developing diabetes, we don't normally offer the test to them.
Now, obviously, you're not involved in fertility. You're involved once a baby's there.
Yeah.
We know that there's a lot of things that affect women's chances of having a healthy pregnancy to start with. But let's say they are now pregnant. What are the consequences of things like weight, other sorts of health conditions that women might have? What effect would that have on their pregnancy?
So probably I will start with the weight, because I think it's more of a global concern at the moment, not only in the UK but also worldwide, because now overweight and obesity, the numbers in women, especially young reproductive age women, is becoming more and more. So when a woman have overweight, for example, with what we call as a body mass index more than 25, or even more if it is more than 30, there are research and evidences everywhere that the risks in pregnancy, both for mom and babies, are increased. So the risks of developing diabetes in pregnancy are increased, and obviously if they do then develop diabetes, then there are other consequences as well for, again, both mom and babies. The risks in developing blood pressure problems in pregnancy, either only high blood pressure in pregnancy or developing a condition, what we call as a preeclampsia, also even higher compared to their counterpart women with a normal body mass indexes. And also with the development of the babies that were born from mom with a higher BMI, that tend to have bigger size. And bigger size means that it's going to be more difficult to get them born vaginally. The proportion of these women who then ended up needing cesarean section, which is a major surgery, it comes with lots of risks and of complications. They all increase as well.
Is there a specific ethnic group that are more liable to these kind of conditions, or is it a fairly even across the board situation? So
basically, we know that with diabetes in pregnancy, the South Asian women, they are unfortunately inheritedly more prone to diabetes, not only diabetes in pregnancy but type 2 diabetes in general anyway, and women from the Middle Eastern descendant as well. So we do offer screening for diabetes to them. With regards to the preeclampsia, the most key factors to that would be a previous history of any high blood pressure in previous pregnancy. So that's why we do then normally offer different sort of pathway of their pregnancy care to try to decrease the risks of the same problem happens again.
And is there a hereditary element here? So if your mother experienced certain things during her pregnancy, for example, we look at the Duchess of Cambridge, who has severe morning sickness with each of her pregnancies. If your mother had gone through the same thing, is that likely to happen to you as a daughter as well, or are they quite often unrelated?
So some of the conditions they do, like diabetes in pregnancy, is family or inheritance plays a big role on diabetes, not only in pregnancy but diabetes in general. Preeclampsia or high blood pressure in pregnancy also sort of influenced by the genetics as well. So yes, they are, and that's part of the screening that we do to all these women, try to stratify the risks and whether we can then modify their pregnancy pathway care, basically.
I mean, it's great that we're very fortunate in the UK that we have a system of support with midwives and then obstetricians and so on. And a lot of men who may be watching, or women are thinking about their partners, how can they help, how can they assist? For the men during pregnancy, is there anything that they can do to help? Is there anything that, so they don't feel completely useless, that the lady isn't having to go through it by herself? What sort of things can he be doing to assist?
I think like this is coming from me as a personal experience as well as a medical professional. I think support is the biggest thing that a partner can give to their sort of expecting partner as well. So a big support. Obviously, obviously pregnant women at the beginning of their pregnancy, it's probably, it's very common for them to have morning sickness or pregnancy sickness. Some of them can be very severe that they need actually hospital admissions because they can't just, can't keep anything down whatsoever. So having a support from their partner is very crucial for them.
Really important part of it.
Very important.
So absolutely a role to play.
It's definitely. I think also throughout there are big research that was done that actually partner support during delivery. So being there all the time for hours of being in labour, actually partner support increases the chance of a mother achieve a normal vaginal delivery. So that's very
obviously
good.
Stress is a major part, and that I know is something we're going to talk about more in our second half. But for the moment, unfortunately, it is time for a break. Please don't go anywhere. We'll be right back. Welcome back to the Health Show, where our topic today is pregnancy care. Now, did you know that the UK was the first country to legally offer 3-parent gene therapy? This time last year, Britain's fertility regulator gave the green light for the country to become the first in the world to legally offer 3-parent baby facility treatments. Now, the techniques would then allow women who carry the disease causing mutations in their mitochondrial genes to give birth to genetically related children, free of mitochondrial diseases. So let's take a look at what this means.
We've taken a historic decision to allow mitochondrial replacement therapy in clinical treatment for patients, which means that those who have families with a serious mitochondrial disease, which results in disability or even the early death of their children, will have the chance finally to be able to have a healthy child genetically related to them if they want to take advantage of these techniques. That's a very small number of people, potentially 3,000 families in the UK and other people abroad who might be affected by this, but we know that many of those people won't come forward. We're expecting potentially 25 couples in maybe the first year to 18 months and maybe 100 to 200 couples who would come from the UK and abroad in subsequent years. There is a lot of uncertainty. There always is when you introduce a new medical treatment, but we think that by making rules around prenatal testing, around extra information given to these patients about consent and follow-up that we want to do on every single treatment and every baby born will allow us to have more information as we go forward, perhaps extending this to a wider group of patients. But today is very much about proceeding cautiously for those patients who have no other alternative. And the UK has been proven possibly one of the best in the world countries to be able to balance that innovation with safety and allow patients to be treated humanely and carefully, but within that balanced framework.
It's fascinating, isn't it, again, watching how technology and science has been able to really reduce the amount of abnormal pregnancies, if you like, so that more and more women can have a normal pregnancy. We talked a little bit before about the general topic of discussion and are people actually talking about it. And there's one of the things that, we've heard from other guests who've been on the Health Show, that sometimes within the Muslim community there's a reluctance to talk about some of the challenging aspects of healthcare and including pregnancy. How do you help couples to basically open up that communication more so that everyone's feeling involved in the conversation?
Yeah, I think being a Muslim, a female obstetrician, gives me lots of advantage to when it comes to deal with that type of patient, because I completely agree with you. Some of the community feels that everything needs to be discussed like within the community, a bit reluctant to seek for help or advice from the outside. What I would suggest to everyone, especially my Muslim fellow women who is planning for pregnancy or who is like currently pregnant, even the Prophet also teach us or ask us to come to the expert when it comes to things that humankind are allowed to seek for progress and advancement in science and technology. It means that when it comes to pregnancy, then I think it is very sensible for them to come to either midwives or obstetrician to try to clarify matters that are unclear for them. I would strongly them to seek the appropriate help for the medical professional, so that if any problems in their pregnancy or in their health in general, it can be picked up and treat appropriately.
And we should also say that, as we touched on in the first half of the show, that it's very much for a man to be involved in the whole process all the way through, taking care of anybody who's needing that help during pregnancy, because it's quite a stressful time, isn't it? Although we know that the vast majority of pregnancies are absolutely fine, just that concern and worry sometimes that, is everything okay? Is it going as it should be? Obviously will need support as well.
Yeah, absolutely. And I completely understand lots of women out there, feeling anxious if they can't feel their baby moves for a few hours, they just become very anxious whether the baby is okay, whether the baby is growing well, whether the baby is getting enough nutrients, whether the baby is actually developing okay, and so on. So I think it's very, very important to have that sort of partner that actually be someone else that a woman can talk to. So I think that's another big role of men as well, to be with the woman throughout not only the pregnancy care, but in the labour process itself. Labour could be a very stressful event for the woman. It is potentially as well for the man, but I suppose if they come through together, they could sort of probably share the strengths together. Absolutely. As well, and it's there are evidences that actually partner support contribute a big success to the woman to achieve vaginal delivery, to decrease the risks of operative delivery, which is that's why we in the NHS we do allow partner to come and be with their wives or their partner throughout the labour. The era where the woman only there attended by only midwife to deliver the baby has gone. It's been 30-40 years ago now.
And likewise, the era of only male medical staff, obstetricians and so on, that's gone as well. So for people who maybe are a little bit concerned that there won't be somebody, a female, to look after them, again, to allay those fears.
Yeah, absolutely. Especially in the UK, I must say that in the UK, female obstetrician, the numbers are keep increasing. So it's very unlikely that in the event of non-emergency that we couldn't find any female doctors or female staff to look after women. Obviously, yes, in the event of emergency, sometimes time does matter. It's probably there isn't any time to find one. But in non-emergency setting, as in clinic or other settings, it should be possible, and it shouldn't even render the woman to come to the hospital. Even in Islamic teaching, it is what we call as a rukhsah, that where actually, if it is an emergency, if it is a life-threatening situation, things can be dealt with whoever helper or attendant who is available at that time, and it is allowed.
One of the things I want to talk a little bit about is nutrition during pregnancy, because obviously it's a time when it's more important than ever. So maybe a word on what people should be eating, what's good for them to eat. But also, we talked a little earlier on about hereditary factors coming through mother to child. And maybe, for example, if the mother, or for that matter, the father, has allergies or conditions or anything like that, what they should do thinking about their unborn child, whether or not they should be taking extra precautions in those situations.
Yeah, with regards to potentially allergy, unfortunately there are so many factors that contribute and causes someone to then develop allergy to certain things. And unfortunately, up until these days, the allergic reaction sort of process, although it's being researched extensively, is not fully understood yet up until this moment. And obviously, because some of the hereditary factors also influence that as well. I would say there isn't much that we could advise women not to eat, or to eat something in order to avoid allergic sort of reaction to the unborn baby. But all in all, we always say is that keeping the healthy and good proportion of food on each meal is very important. And for a certain group of people, say for example, the certain group of people with higher body mass index, which are overweight or obese, we always say is that in pregnancy, if you could cut off the amount of carbohydrates, especially the simple carbohydrates that they take, it should then decrease the risks of developing the diabetes in pregnancy.
And those carbohydrates would be things like bread, some of the rices and things like that.
And not necessarily cut them off completely, but probably change, for example, from the slice of white bread to the brown one, because we know that the brown one would be more complex carbohydrates, and then the glycemic index is better. So things like that. And there are, across the NHS, there are like dietitian that would be more than happy to see them should they need
So there's
dietary
always lots
advices.
of help. And as you say, the weight is a major issue. And I know there's been a report fairly recently, from Embrace, which talked a lot about that. Share a little bit more of that with us.
Yeah, so basically, Embrace is a report that the UK has been doing regularly to look at the cause of maternal morbidity and, most importantly, mortality or maternal death. And for the several reports that had come out recently, high BMI are related to some of the maternal deaths, unfortunately. We know that women with the higher BMI, they are at risk of developing all these complications, including high blood pressure, diabetes. Some of them ended up in cesarean section, and obviously doing a surgery in a high body mass index woman is not the easiest. That's why their complication rates are more. And post-delivery, we know that cesarean section increase the risks of thrombosis or blood clots in their lungs and legs. And having a high BMI itself is a high contributing factor to that, and plus cesarean section, plus delivering a baby. So in combine, they carrying more risks compared to other women.
What's the advice regarding how much you should diet by? You're saying they're cutting down carbohydrates, but obviously you don't want a pregnant woman going on a really severe diet and therefore depriving their child of nutrients. So is there a lot of advice available out there in terms of advice? For example, would your doctor or midwife be able to be specific about the kind of diet that you should be going on?
Yes. So with regards to advice and help, every maternity unit will have the dietitian, some of them even on site. With regards to how women should then adjust their diets, obviously trying to lose weight in pregnancy is not the best, because the baby needs those nutrients in order to grow and develop well. So we always say is, if you are planning the pregnancy, if you know that you're overweight, then try to adjust your weight, try to lose weight before the pregnancy. That would be the best. We know that the outcome for both mother and baby are best.
And the chances of conceiving healthily are greater as well, aren't they?
Absolutely. We know that only by decreasing your weight by 10%, then your chance of achieving pregnancy, achieving good outcome in pregnancy are much better. Now, if the overweight woman, then pregnant already, then obviously that's not the best time to try to think about losing weight. We always try to say that in the first 6 months of pregnancy, then the baby wouldn't need as much of sort of extra calories that the mum would have to take.
You don't quite have to say you're eating for two
Exactly.
yet.
Those are the complete myth that are out there that we are, as a professional, try to say that's not true. Only at the third trimester, basically, where the baby is actually needing more calories from mum, and it doesn't need like double your actual meals. Only
That's just a bit of an excuse then.
I think so.
Now, what about two other things we haven't talked about yet? One being exercise. Of course, that's a good route to a healthier lifestyle and maybe losing a few pounds.
Yeah.
What kind of exercise is best during pregnancy, and does it matter the different stages of pregnancy, what type of exercise you do?
Yeah, so basically I would probably then divide the women between the one who normally is already active and doing regular exercises even before the pregnancy, and there are a group of women who normally probably lead like sedentary lifestyle. They don't do exercise as a routine. So for this women who they normally do exercises, then obviously they need to adjust their type of exercises in pregnancy, because obviously if they normally do like high impact exercises, obviously that's not suitable in pregnancy. They probably need to look at the exercises that would allow them to lead a good healthy condition in pregnancy. So swimming are very advisable. Brisk walk is very advisable. And again, some of the women probably do yoga. There are prenatal or antenatal yoga classes in lots of laser centers, so they possibly could attend that as well. Now, with the women who they don't normally sort of active, and then in pregnancy, lots of women, they then think that I need to do my best to allow the child or the unborn baby to grow and to reach their optimal potential. Now, these women, they could start with probably easy 15 minutes of walk 3 times a week, for example, and then they probably can build that up throughout the pregnancy. They probably can try swimming or, again, yoga, and there are a very good leaflets that the Royal College of Obstetrician and Gynecologists just released about recreational exercises in pregnancy. I would recommend women to come, and it's accessible through their website.
And I think that's the main thing, isn't it? You don't have to rely on Dr. Google anymore.
No.
You can actually get a lot of advice from your midwife, and if your midwife hasn't got that immediate advice, they will be able to point you in the right direction.
Yeah.
The last thing I want to talk about a little bit is about sleep, because especially in the third trimester, it obviously for a lot of women it's a little uncomfortable trying to get that right position. How important is sleep? And I saw a report actually just today about sleeping positions. What's your view on that?
So basically, in pregnancy, the more advanced the pregnancy, then obviously the size of the womb, the size of the baby and placenta in the abdomen or in the tummy is going to be getting bigger and bigger. And if you're lying on your back, we know there is a big vessels at the back that's coming from the heart, called the aorta, will be compressed completely. Well, not completely, but will be compressed. And that means less blood supply will go to the womb. That's why we always advise, if it's possible, for a heavily pregnant woman to try to sleep on their side, so that to release or to avoid that compression to the aorta, so that more blood supply can go to the developing and growing baby in the womb.
And does a pregnant woman need more sleep? Should she be really focused on having a good deal of rest? Or, again, is that one of those housewife tales?
So I suppose it is very important for pregnant women to have a good, decent, appropriate rest. Obviously, because pregnancy itself is a stress to the body. And number 2, it's very important for the pregnant woman to get the rest, because obviously it allows the body to then distribute all the blood supply and nutrients and all the energy to the unborn child. We always say that having a good at least 6 to 8 hours sleep per night is always good for the baby and for mom. And we know that mother who sort of sleep deprived for whatever reasons, and one of them probably their job, there are increased risks that the baby may then be born smaller compared to the average size of baby that would expect it at that gestation.
And what would your general advice be? Of course, we understand most of this is common sense. Look after yourself, you'll look after your baby. What other specific tips would you give women during pregnancy to just look after their health, to increase the chances of a healthy pregnancy and a healthy delivery?
So I would normally ask the women to try to allow some time for them. Obviously, if they work in this era, lots of young women, they're sort of active and they have their work. They should know that the government, especially the UK government, they do allow women to have their maternity benefit. So in the NHS, if you do get pregnant, we provide a certificate which then, if you give it to your employer, then they would allow you to take all the maternity benefit, including your maternity leave. And also with regards to whether you need to then limit your day-to-day activities, your social activities, I would say you should lead your normal life. Obviously, if some of the health lifestyle changes that you could try to change, say for example, if you normally smoke, then try to cut it down or to stop it completely, because that's very important for the growth of the baby. If you normally drink alcohol for social reasons, try to cut it down. If you normally eat lots of fast food, for example, which obviously contains lots of carbohydrates and unhealthy fat, try to change it to more sort of the food that you prepare yourself.
Well, you've given us a huge amount of advice today, and I think the main message that's coming out is, use common sense, but also use the help that's available through your midwife, who will then guide you to an obstetrician if it's required. One final bit of advice, if you could. What if you could sum up in one sentence to pregnant women or anybody watching who knows someone who's pregnant, what would that final bit of advice be?
I would probably say that pregnancy is not an illness or a medical condition. It is a physiological process that lots of women, millions of women in the world go through their lifetime. Majority of them would be the outcome of the pregnancy would be good for both mums and babies, and the medical professionals are there to offer the help and advices should you need them. But most of the time it should be okay, and we're here should you need anything. And
it's great that there is that much help available. It's been fascinating finding out all about this, and I'm hoping that for people watching at home that they feel a little bit more confident and comfortable surrounding their whole pregnancy, and indeed that they'll have a happy pregnancy.
Yeah,
unfortunately, though, that is all the time we've got for today, and I'd like to thank Dr Dyah Prawesti for coming into the show today and sharing her experiences with us, as well as some of that vital information regarding a woman's health during her pregnancy. If you'd like to find out any more, then please do email us at healthshow@islamchannel.tv. Once again, we must stress that should you suffer from any medical problems or have any concerns, it is always highly recommended that you contact your doctor or GP, as the Health Show gives you an alternative viewpoint to the medical and health topic being discussed. Again, I hope you enjoyed the show. Thank you again for coming in.
Thank you.
For now, it's goodbye, and we'll see you soon. Assalamu alaikum. Thank you.